We now request Dr. Vivek Gupta to come on stage and deliver their presentation.
ICC has been a very important place for me. I don't know whether how many people will know that it was actually launched in 1999-98. So I was one of the founder members along with Dr. Rajiv Lochan in Apollo Delhi, who is now in Dubai, actually is working there. So we always been coming here. Can we have my slides here? So I'm thankful to the organizers for giving me the opportunity. I have another talk tomorrow, which is TAVI, bedside to bedside. That will be more interesting. This case is not that challenging, I would say, but still it went, finally the result was okay, but there was some hiccups in between, so I thought I should share my thought process during the time when I was doing the case, because whenever you do coronary case, you always have a fear that you should not fail, number one. Secondly, I always tell all my juniors, colleagues, that when you do a case, your success, the more important than success is the safety. The safety of the patient should never be compromised. You should send that patient home even if you have not been able to successfully completely revascularize the patient. And this actually works in the long run. Sometimes people try to do the best cosmetically, and the cosmetic result is not that important as the clinical benefit achieved to the patient by doing revascularization. The complete revascularization may not be required. Many times you have optimal revascularization, which is good, more than good to the patient. So if you always feel that the patient is your family, then you will take the best decision. Number of stents do not matter. You have to do the best flow. The treatment should be optimal, and the patient should do well. Safety is most important. Success is second important thing, my feel. So this was a case where I struggled in between, but finally it was okay. The 45-year-old diabetic female with a history of angina, young patient, class 2 to 3 for past 4 years. She was avoiding bypass surgery for a long time. 2D echo EF of 25% with, of course, many territories which were having a functional thing, and the patient was continuing to have angina. Coronary angiography revealed severe triple vessel disease, CTO of LCX and RCA, and complex bifurcating stenosis in LAD and large diagonal. Patient was advised bypass surgery multiple times, but she continued to avoid surgery. Young patient, and of course they must be having stigma against the bypass surgery. Many of the patients do have, unless they land up with a problem with the left pain or something, where you really tell the patient that you're sitting on something which can volcano. When we use the word, I have stopped using this word actually, because this sometimes really gives I always tell the cautious approach. Tell the patient that the patient is serious enough, but don't tell that sitting on the volcano and all these things, which I don't want personally. Many surgeons have been doing it for last so many years. Angina episodes increased. Coronary angiography repeated in March 2014 revealed similar findings. Stage angioplasty was planned and written informed consent of complex PTCA was taken. CTO of RCA was first planned in the first sitting. I never wanted to do the second sitting at the same time, but of course the second patient was here. So let us have interesting videos. You can see this circumference is not that large a vessel, but it's a CTO, but it's filling it intricately, and somehow it's not looping again. Sorry, I have limited time, so you can see this is a bad lesion, something like parallel LAD, but of course doable. But I thought that I should not do this. Let me have at least the left-right system working, and this was the lesion, which was RCA CTO, and it did not appear to be so complex actually. If you see, I would like to the interventional cardiologist have a look that the distal is filling and it's an antegrade flow, and somehow it's coming through that, and I thought I will be able to do it with a simple whisper wire, which I normally use. I normally use whisper wire in all patients. Sometimes my colleagues and my technicians say why I was using it. I feel comfortable. So I thought I will be successful, and I failed here. So whisper wire with the balloon support, as we normally do, did not cross the lesion. And then finally we were successful with the Gaia CTO guided wire. It did not take much time. It was only 2, 3, 4, 5 minutes. I think it helped me, and I was very happy. I think I will be able to complete it. Of course, pre-delegation with 1.5 and 2 millimeter balloons, and flow was established. This is important, interesting place where you can see the flow was established, and we did not worry about distal part, because in the beginning I thought that the lesion is here to here, not the distally, so I was not worrying. So I immediately thought of deploying a stent, which was flow was established, 2.25. Artery did not look so much short remission by 20 kg. and proximal RC stent was to be planned, but there was no flow distally. So this was the point where I struggled to find the reason why. I had not taken the balloon here, so this is interesting. Sometimes we take a balloon blindly and you may have dissected it, but still the dye was filling. I mean, if you see this, I would like to have some views from the other interventional cardiologist. If you repeatedly see this, the distal flow is not there and there is a dye stain. And I have clearly remembered that I did not take the balloon to that area. So why this was happening, we don't know. Still today, I don't know. So this was proximal stent was to be planned, fluid was deployed stent, dye staining distal RC, possibly intramural dissection, wire, maybe a wire could have done it. No memory of any pre-dilatation at that location. Patient was reasonably stable, so there was no hurry as such, but it was late evening. So I initially thought that since it is a very highly radiopaque wire, I should change it back to the whisper wire. And since we did not take we could have taken something more, some other catheter there, but we did not plan to have softer whisper wire, but failed late evening time, first hemodynamically stable. We could have taken something else we proceeded to proceed with the dia, and so thinking that this is a dissection area, we pre-dilatation distal segment, which may not be required, but for the ease of putting the stent, we deployed the long stent, science era, 2 mm into 38. Did not know exactly diameter. We did not do IVS or OCT. So nice flow established. This is the point, turning point. So it's actually learning why this was simply wire which had caused dissection. We could have done some imaging to really find out what was the reason. And without changing the wire, you can see now the things were simple. You had a good flow distally, and now the only proximal stent was required, which we did. And the patient turned out to be apparently simple case with lot of hiccups. So learning, that's why I wanted to present this case, because a small learning, and you can see that the final result is perfectly all right after doing nicorandil and intramural. I always give intramural nicorandil other NTG because I feel that the patient will not have fall in the blood pressure, and this was with the support of TPI, and this is the final result. So this is a common, I would say, hiccup which happens in many CTOs, but still for the sharing my thought process, I thought of presenting this case. 45-year-old, just to conclude, female with 3-way TVT, 2 CTO, completely refused bypass, planned first stage procedure for RC CTO first, and then complex PCI of LAD in separate sitting, which we'll do soon. The patient is on regular clinical follow-up. Ischemic cardiomyopathy, successfully PCO, hiccup of distal dissection, RC is now fully comalized, but patient is better, angina is much less, and 6 months of the clinical follow-up, I think almost 6 months. Rest of the vessel treated need to be treated soon. The patient is very apprehensive. Although patient did not know that we had some hiccup, but so I personally feel that this was where I could have, that means the wire could have caused dissection. This is what I personally feel. And we had not done the pre-dilatation. But finally the success is there and the patient is doing very well. Thank you very much.
Could you see the distal flow? We could have taken a microcatheter.
This is what I'm saying, that we did not do that. That was the only thing which we could do, which I missed. But I thought this is put a stent quickly and do a balloon, and this was a dissection and microcatheter. And in fact, microcatheter could have been used also to change the wire. I don't know why technician did not bring it. I thought it was late evening, 9 p.m. So he said, okay, please do this. You will successful with the Gaia. Why changing the wire? You continue this. And I was not comfortable with the Gaia wire because of the too much of radio opacity. So when in the late evening, 9 p.m. without anesthesia support, at that time he was also not there. Patient is 25% ejection fraction. Although stable, you never know when she becomes unstable. Perforation could have caused. These things are anticipated. I always tell all my juniors, there are a lot of junior people, senior people are here. If you anticipate a problem, you will never have a problem. So you should anticipate that these things can happen, if you know. And my technician says, why are you thinking it should not happen? I said, I'm just thinking. I think that's why I take precautions. Because technicians say, bahut darte ho, hame darne wali baat nahi. I do quickly, fast, but take precautions so that patient should not further deteriorate. That's most important. Thank you very much.
Thank you, Dr. Vivek. Next case will go to Arjit Kumar Ghosh. Last presentation.